Bismillahirrahmanirrahim. Hello everyone. This is the first video of a series about hyponatremia. So we are going to, in this video, we're going to talk about the importance of this topic, since it's really very common and really important for anyone who is practicing acute medicine or hospital medicine. So we're going to talk about the basic pathophysiology, clinical features, hyponatremia, chronic acute hyponatremia, and chronic hyponatremia, and we're going to talk about osmotic demyelination syndrome. Okay, so by definition, hyponatremia is any plasma sodium less than 135. It can be divided into mild, which is between 134 and 130, or moderate, which is between 129 and 125, or severe hyponatremia or profound hyponatremia, which is anything below 125. It's the most common electrolyte abnormality in hospitalized patients, about up to 30% of medical inpatients, and about 50% of cases are acquired actually during hospitalization. 20% of patients with heart failure also might have hyponatremia, and also you might see it in cirrhosis, among other diseases like kidney problems and drug-associated SIDS and many others. So it's really very common, it's very important, and that's why we're going to talk about it. Okay, so for acute hyponatremia, which basically by definition happens within 48 hours, the main pathological problem is that there's generalized cellular swelling, meaning water will move from the hypotonic extracellular fluid to the intracellular fluid because of the hypotonicity in the extracellular fluid, and that will lead to cellular edema, and that's really kind of the main pathology associated with acute hyponatremia. So it's a primarily neurological problem, mainly cerebral edema, and if you can imagine, if you have like a rigid skull and there is swelling of the brain, that's increased intracellular pressure can lead to a lot of symptoms. So the early symptom might be a little bit specific, like nausea, headache, vomiting, mild confusion, sometimes agitation, and fatigue. As you can tell, these really are very non-specific symptoms, and there are other severe complications that can happen if the acute hyponatremia is not treated. So patient can develop seizures, and probably the most dreaded effect is brainstem herniation, coma, and death, and that's why we want to avoid that. And also a little bit remote from the CNS is development of neurogenic pulmonary edema, which is basically normal pulmonary capillary wedge pressure, and that can lead to normocapnic or sometimes hypercapnic respiratory failure, and that's because of the effect of the cerebral edema on the lung. This is called neurogenic pulmonary edema. So keep an eye on the patient oxygen saturation, and this most of the time this happens in really severely sick patients, most of the time in the ICU or neuro critical care. Also, another situation where acute hyponatremia can happen is in after surgery, which is called like iatrogenic hyponatremia. So patients with surgery sometimes they do have associated pain, blood loss, hypovolemia, and many other factors that can actually lead or stimulate the production of ADH or AVP. We'll talk about that in a few minutes. And in addition, if the patient is giving hypotonic fluids, then that can rapidly lead to development of hyponatremia. Another situation is exercise-associated hyponatremia. So, for example, in marathon runners and other endurance events, then there might be also an increase in the AVB. And then if the patient drinks a lot of free water or any hypotonic fluid rather than isotonic fluid, this can also lead to development of severe acute hyponatremia. Use of recreational drug is another common scenario for development of acute hyponatremia, like ingestion of ecstasy, and this can lead to rapid and potent induction of both thirst and increased ADH or AVB, and that can lead also to acute severe hyponatremia. So as you can see, this is kind of the most common situations where acute hyponatremia can happen. And if you have a documentation that the patient sodium was normal in the last 48 hours, then this by definition acute hyponatremia. If not, then you assume that the patient is having chronic hyponatremia, and we're going to talk about that in the next slide. Now this is just another diagram kind of illustrate the adaptation that happens within 48 hours and after 48 hours. So basically, this is a brain, blood-brain barrier, and the blood vessels inside the brain. So when there's hyponatremia, there's less sodium and more water. So usually sodium can really get outside or penetrating most of the cell membranes, but the blood-brain barrier is actually an exception. It doesn't really allow sodium to move, but water still can move across the cell, the blood-brain barrier. So that's really important, because what happens when you have hyponatremia, this is a brain vessel, then there's less salt and more water. Water will move from inside to the outside, and that will lead to the development of cerebral edema, like we explained in the previous slide. So this is kind of also scheme to kind of explain that in a little bit more detail. So what happens if you have a normal brain and then for some reasons the patient develops some acutely or slowly hyponatremia from any reason? As we said, that will lead to cerebral edema and water retention or water gain, and that will lead to symptoms of increased intracellular pressure. And just like our body always does adaptation whenever something abnormal happens. So in this situation, the first adaptation will be the cells will try to eject the sodium, potassium, and chloride initially. These electrolytes will try to be removed from the inside of the cell to the outside, so that the inside of the cell will have more water, and water will move from the inside to the outside. So it's an attempt from the brain to kind of expel water outside. And if the hyponatremia continues, then the neurons will not only expel these osmolytes, but also will expel other organic osmolytes like glutamate, creatine, glycine, and taurine for the same purpose, to try to increase the water content from the inside the cell, so that water will go to the outside in an attempt to decrease the cellular expansion or cellular edema. So that process takes some time, and if the patient had received treatment for hyponatremia, then hopefully they can regain normal brain. And if the treatment is improper or like overcorrected, and the sodium concentration in the extracellular fluid is really replaced really quickly, that can lead to osmotic demyelination, and we're going to explain that in a few minutes. So it's really important to know that in some situations the adaptation process can be impaired a little bit. So in during menstruation in females, also in pediatrics, kids, patient with SIDH might have improper adaptation. Also, patient with hypoxia. So in these situations, you need to really be very careful, because this patient can really develop severe symptoms from hyponatremia, especially if it's acute. And that's because the adaptation process that happens in the brain, for some reasons that's poorly understood, they might not be able to adapt, and they're more likely to develop hyponatremia. I remember during my residency training, I had a young lady who was doing heavy exercise, and then she took a lot of water. She developed severe hyponatremia, and she ended up in the ICU. But we managed to kind of restore the sodium, and after 2 or 3 days, she was out of the ICU and feeling much better. She was obtunded. She had really severe symptoms, severe ICP. So she was young. Maybe she was that's what happened during menstruation. I don't really remember, but keep that in mind. I think it's really very clinically relevant. Okay, so what about chronic hyponatremia? So by definition, if you don't know the onset of the hyponatremia, or that it's more than 48 hours, this is chronic hyponatremia. Is it really asymptomatic if it develops slowly? Not really, maybe. There is usually some subtle symptoms like, gait abnormalities, some cognitive defects. The family might notice that the patient is not really behaving as they used to be, some fogginess in of thinking. Really subtle, non-specific, again, symptoms can happen with chronic hyponatremia as well. There may be also like mild postural symptoms, some muscle cramps, some generalized weakness, and also increased risk of falls, and that's really important. But there's also increased risk of bony fractures. So now this is not really just because of the falls, but it could be because of the what's known as hyponatremia associated decreasing bone density. So if you remember, sodium is not just present in the intercellular fluid compartment, but also is actually abundant in the skin, in the cartilage, and in bone as well. In fact, in some experiments in rats, they found that chronic hyponatremia has been shown to be a more potent cause of osteopenia than a vitamin deficiency. So, whether that applies to humans or not, we don't know, but it makes sense because, again, if you notice, it's a lot of musculoskeletal symptoms associated with chronic hyponatremia. And there's actually a nice article about that if you want to look it up. Mild chronic hyponatremia is associated with falls, unsteadiness, and attention deficit. So definitely, even if the patient had chronic hyponatremia, even if it's a little bit mild, it's probably worth trying to treat it and look for underlying cause and try to reverse it if possible because of these associated symptoms. Now let's talk about osmotic demyelination syndrome, and this is one of the main reasons why people emphasize the treatment of hyponatremia is really kind of try to avoid this. It's relatively rare, but it's really serious complications. So basically what happens if you have a rapid correction of the hyponatremia, unfortunately sometimes even with appropriate correction, as you will see, and we talked about the adaptation mechanism, and we talked about the loss of organic osmolyte from the inside of the cell as an adaptation mechanism. So after some time, there will be a deficit of these organic osmolyte in the inside of the brain cells, especially the oligodendrocytes. So these combined, if you can imagine, there is abundance of sodium now in the extracellular fluid, and there is less osmolytes, so more water inside of the cell. So what do you expect? Water will move to the other way around. Initially, it moved to the inside of the cell, causing cellular edema, but now it's moving from the inside to the outside. And this can lead to the degenerative loss of the cells, which is basically shrinking of the cells and their death. And that can lead to disruption in the integrity of the blood-brain barrier, and this will probably stimulate, immune mediators and can lead to demyelination. So this is, again, kind of a theoretical pathophysiology about the ODS, although the exact mechanism is not well understood. But demyelination could be the main player in this pathophysiology. So again, it's rare, it's not very common, but it's serious. And as you can tell, this syndrome ODS can also occur in patients with acute hyponatremia, right? And they call it monophasic in this situation, basically because with acute hyponatremia, there's abundance of sodium in the extracellular fluid and less in the intracellular, so water will move from the inside of the cell to the outside, so right away. But in ODS, due to hyponatremia, it's biphasic because initially there is shift of water from the extracellular to the intracellular, causing cellular edema, and then with overcorrection or appropriate correction in some situations, there is other way around. The water will move from the inside of the cell to the outside, causing the ODS, and that's why it's biphasic. So that's why the pathophysiology of acute hyponatremia might be similar to the ODS. So where does this happen? It can happen anywhere in the brain, but classically it happens in the pons, and that's why it used to be called the central pontine demyelination, but it's not the case anymore. Theoretically, pons used to be or maybe still the structure wherein the delay in the reaccumulation of osmotic osmolytes is particularly pronounced, meaning this is the organ or the part of the brain where the adaptation mechanisms happen the most. But again, this can happen in the pons and or other areas as well, including cerebellum, lateral geniculate body, thalamus, basal ganglia, and cerebral cortex or subcortex. So having said that, you can expect that the presentation of ODS is really very variable. Usually what it happens after a day or sometimes even more after the overcorrection of the hyponatremia. It can happen up to a couple of weeks even. So there's a really wide range when this ODS happens after the overcorrection. So you have to keep that in mind. Sometimes the patient might be discharged home and then they might develop it there. So and then the clinical presentation depends on where the most affected organ. So if it happens mostly in the pons, you can expect some flaccid paraparesis or quadriparesis, sometimes even plegia, dysphagia, dysarthria, diplopia, the lock-in syndrome, which is really kind of a really tough situation to have, and or loss of consciousness. But again, there might be like variable presentation depending on where this ODS happens. So it can happen, it can present with ataxia, mutism, Parkinsonism, dystonia, and catatonia. Risk factors, this is really very important because these are the patients who might have ODS even with appropriate correction. So people with severe hyponatremia, if they have very low sodium to begin with, they're more risk for ODS. Patient with alcoholism, patient with malnutrition, patient with chronic diarrhetic use, especially if they have hypokalemia, and patient with liver transplantation. Be careful with this patient if they have hyponatremia because they can develop ODS more rapidly and they're prone to develop ODS more than any other patients. Diagnosis is basically clinical based on these symptoms and the presence of overcorrection and the history of management of hyponatremia, and then MRI can aid in diagnosis. It might show some hyperintensity in the DWI early, like what happens in stroke, basically. Also, there's something signaling in the 2-2 and flare, as we will see in the next slide. Treatment is supportive, so depending on the symptoms, you try to just make sure, follow the ABCs and physical therapy, speech therapy, occupational therapy, and just supportive care, really. Unfortunately, there is no definitive treatment of ODS if it's become well established. Outcome is very variable. Some patient might have full recovery. Fortunately, that hopefully will be to the most patient, but some patient might have some disability, might be mild, might be severe disability, and unfortunately some patient might die as well, as you can expect. So, and that's exactly why we're always talk about ODS in patients with hyponatremia due to overcorrection. So this is just an example to give you a visual picture about how it looks like in MRI. So as you can tell, this is a little bit hyper intense signaling here in the DWI image, and this is in patient, and you still see the T2 and flare due to the presence of probably some edema demyelination as well. So remember, the diagnosis is not just by imaging, but clinical presentation, typical story, plus the imaging in front of MRI. Okay, so we will end here. This is a small quiz, so pause the video and take a look at it, and we will talk about the answer at the beginning of the next video when the journey of hyponatremia continues. Okay, see you then. Bye-bye.